Once we have a patient whose history and exam and x-rays are suggestive that it's causing pain, that the impingement is causing pain, we do something called a differential injection. Hip pain is a little harder to deal with than shoulder and knee pain because it's a deep structure. You'd like to be able to confirm, you can touch the medial meniscus, you can touch the lateral meniscus just about through the skin. But with the hip, we like to make doubly certain once we think it's this problem, we'll inject the hip with a local anesthetic. And then we'll make sure that all their pain goes away. If the pain's coming from piriformis syndrome or their back or bursitis or tendonitis, it's not going to get better if you just numb up the inside of the hip. So most patients who get to the point of thinking about surgical treatment, getting their impingement fixed, will undergo a differential injection. Or anybody who wants to be 100% sure that that's what it's coming from. And here's a video of somebody getting a differential injection. And basically, we have a live x-ray machine, so we're sure we're getting the needle in the right spot, and we can follow the needle down on x-ray, inject the material into the hip, be sure that we've anesthetized the whole hip, and then we can examine them right away. We can try the impingement test, we can try some different things, and make sure all their pain is gone now that we've anesthetized the inside of their hip. Here, this is what it looks like when we're doing the differential injection. On your left is a normal arthrogram, on the right is an arthrogram with a patient with a torn labrum. But basically, we get that confirmation that we've injected the hip, that we can see that we've numbed up the whole inside of the hip, and then we confirm that their pain is gone. And you can see the numbing medicine doesn't really go outside the hip joint, so if something else is causing the pain, it won't go away when we numb up the inside of the hip. Those patients are asked to keep a hip joint injection diary. Basically here we just ask them what things hurt before. It hurt every time I was digging for the ball. It hurts when I go upstairs. It hurts if I sit for a long time. And they write those things down on one side. And then they say, after the shot, it didn't hurt. Or it used to hurt 5 out of 10, and now it hurts 1 out of 10. Or they just give us a paper trail confirmation of how well the injection worked. Now, I don't need to show to this group, I don't need to show pictures of sports that produce impingement, but just to emphasize a point. This is a person who's digging for the volleyball. This is, actually this person has pretty good technique. It doesn't show up too well here. They keep their hip a little bit abducted. It's the girl especially who comes down right in, with her leg right on her chest. It gets that flexion and a little bit of internal rotation. Some volleyball players go either right or left when they're digging for the ball. Some always go to one side. It's what they've been telling me. It's the patients who go to one side, it's always the side that they dig down on that seems to have the most problems. That's the one where the impingement's taking place. So. Apologize, some of these videos don't project as well up there as up here. I never paid a lot of attention to hockey players' hips and how they moved until this problem came to light. But here we have a hockey player who's going to be skating, and to get a good video, we have him skating on a simulated, like a treadmill for skating. But they really flex their hip up quite a bit, and to get their skate to dig in, they adduct their leg a bit, and they dip their knee, so they really are flexing and internally rotating. They're basically doing like a little mini hip impingement test every time they try to skate hard. See if you can see this guy skating up there. You can see it to a certain extent. But you can see how he brings his skate way into the midline, and he really drops that knee and pushes way out. That way he can get the edge to dig in a little bit deeper. And so after volleyball players, my next biggest group of athletes with hip impingement is hockey players. He's got a lot of force on the hip there. There are sports that are hard on maybe all your joints, but certainly gymnastics and things can be hard on your hips. Doing squats can be hard on your hips. This person's showing, again, good technique. People who are doing squats who might have a little bit of impingement should pay very close attention to keeping their knees apart so they're not bringing that femoral neck any closer to the midline and bumping the... And you can tell if you watch somebody who actually bottoms out with their hips while they're doing a squat, they can keep that lordosis in their back until the point that their femur and their acetabulum meet, and then you'll see if they go down further, they kind of lose their lumbar lordosis because now they can't bend their hip anymore, and the bending has to come at their back. So how do you treat somebody? You made the diagnosis of femoral acetabular impingement. What are the treatment options? Well, if they haven't caused severe pathology and they just rest, those tissues can repair. All of our tissues undergo strain from sports, from other activities, and they repair over time if we quit irritating them. Some patients, they rest a bit, it doesn't go away, they can try modifying their activity. If you don't put your hip into that position where the two bones are bumping into each other, you're going to get rid of a lot of your symptoms. Stretching and strengthening, a little controversial. We mentioned Reinhold Gans, the first guy to really publish on this. He's not a big proponent of sending people to therapy. Whatever you do, don't give them stretches that cause their femoral neck and their acetabular to bump into each other. You're making things worse, not better. So if my hip doesn't go that way, so I'm going to try really hard to make it go that way, isn't a good way. I'm going to stay away from that one. And then if it's bad, if they try some of the conservative things, it's bothering them a lot, or they're unwilling to modify their activity, surgical correction of the deformity is possible. So we talked about allowing the tissues to repair. If you imagine anybody's hip, if you bend it up far enough, eventually you'll impinge. We don't want it to make that all pathology. We just need to back off so you don't bump it quite as often, quite so hard. Something as simple as going from catcher to outfield can make a difference. If you change your position where you don't have to put as much flexion on your hip, you may not have the symptoms anymore. Incidentally, if you like follow things, this is exactly the sort of problem that Alex Rodriguez has. So even infielders, people who put a lot of flex onto their hip can have this problem. But get into a position where you don't have to flex your hip as often. Learn to flex with external rotation, with your legs apart, and with a little more external rotation that gets the two bones away from each other. Change sports. If you're having a lot of pain in your hip playing hockey, you might not have that pain if you're playing basketball or something where you don't have to flex your hip as much. Hard to do as patients or players get older, but especially with younger patients, that's an easier idea. Like I said, stretching and strengthening is a little bit controversial. In the United States, most doctors who are treating femoral acetabular impingement send patients to physical therapy. We ask them to avoid those positions where they get impingement, but do some kind of core strengthening and some balance training so that they can keep their hip in a good position and not end up putting a lot of strain on the joint. And certainly emphasize programs that don't produce any impingement. So let's say you've failed conservative treatment. You have an injection that shows that it's coming from your hip, and you have impingement in your hip. How can that be corrected? And there's basically two surgical ways to correct that if you want to divide it up. One is open surgery, and the other is arthroscopic surgery. And this gives you an idea of the open surgery. You have a patient laying down, so their torso is up here to your right. Their leg is down here to your left. You can see this is their trochanter. We've dotted that out with some little purple lines. That's the iliac crest, so it gives you an idea in the front and back. This is the incision that we would use for a traditional total hip. I also use this slide for mini hip incisions. If we're doing a mini total hip, we do it through that little incision back here. But this is the incision that we use if we're going to correct the femoral acetabular impingement through an open surgery. We incise the skin, and we dislocate the hip and basically take what looks like a chisel and a hammer and get the extra bone out of the way. So this is an example of a dislocated hip, and we get the hip out of socket. We have a way of measuring where the extra bone is, and we carve that extra bone away using we call it an osteotome and a mallet, but it's a chisel and a hammer. This is one of my early patients, and when I was treating these patients initially, especially if they were big or muscular or just going to be really difficult scope, we treated them open. And so this is a young man I treated open, and he had a really bad case. He'd had impingement since he was playing hockey as a youth. He'd gotten into college, had to give up hockey a long time ago. He had torn his labrum, you can't see that on the x-ray, but he even developed a big cyst up in his acetabular head. Basically, he was having trouble walking several blocks at this point. We did the open surgery, we dislocated his hip, we shaved out the extra bone, and when you dislocate the hip, you have to take off the trochanter, you repair the trochanter back with those screws. And he did fantastic. So this was a kid, he had a big problem, he had a big surgery, and yet, while the recovery's a little bit longer, the open surgery is effective, and he did well. By far, most of my patients, in fact, I haven't done an open one now in over a couple of years, but almost all patients now get this done in my practice arthroscopically. So we can achieve the same bony changes by using the scope. And many of you may have gone to surgery before to see athletes who've had knee scopes or shoulder scopes, but this is what it looks like doing a hip scope. A hip scope has a lot more equipment involved. The patient is lying on a table here, and this is covered up with a lot of drapes, but this is a fracture table. It's the same table we use for treating broken bones, so we can put a little traction on their leg, and we can pull the joint apart a little bit so we can get inside the hip joint. There's not naturally a lot of space in the hip joint. So we have them in traction. We have the arthroscopy equipment that goes through the small incisions. The incisions are the same as you'd see for a knee or shoulder, just a centimeter in length. And we put the arthroscopy equipment into the hip, and we can see the arthroscopy photos or the arthroscopy video on the screen. But at the same time that we're doing the arthroscopy, we can also see with live x-ray where we are in the bony anatomy and how we're changing the bony anatomy. So we are looking at it with video streaming, and at the same time we're looking at it with live x-rays. When we're doing the hip arthroscopy, it's a little bit difficult. You can feel how to get into a shoulder or a knee pretty easily. With the hip, we have to use the x-ray machine to help find the anatomy without bumping into any of the bones. So we take a needle, and under x-ray control, we put the needle inside the hip. Then through that needle, we can place a little wire, and the wire goes in through the needle. So now we know we're in the hip. We can confirm that with the x-ray. Then we have these little series of dilators. So we take a little metal device and make that hole that we're going to use to look into the hip a little bit bigger so we can fit the scope in. So like several steps just to put the scope in. So that's why it takes a bit longer than the knee scope. Now we're going to show a few videos. And these don't project extremely well. Some of it I'm going to have to describe more. You have to use a little bit of your imagination. But you should be able to see see what we do when we do the hip scope. The first video, let's start it here. I'm going to put K, push K. See if I can describe this, how much we can see here. It looks out perfect on the computer. Really, you can't see hardly anything up there. But in the first part, after we make that little hole, we cut the capsule, make a little bit more room. I don't know if I can back up. Let me try that again. Yeah, I pushed the wrong button. See if any of it shows up any better. See if I can see that. But basically, yeah, you can't see that too much. I'll see if any of it shows up good. Otherwise, we'll just keep going. I don't think it's going to show up. We'll try one more time. We tried really hard to make these videos. See if we can make them project. I'm just going to let that go and see if any of it starts to show up. But we have to make little cuts in the capsule. Yeah, here it shows up a little bit better. We're making a cut in the capsule so we can move our instruments back and forth. Obviously, it's a pretty tight capsule. Unlike the shoulder and the knee, it's harder to move your instruments around. Here's the ball of the femoral head. The acetabulum's over there. Here we're probing on the torn labrum. So there's the labrum there. This one tore, and at the base where it tore, there's a lot of calcium. It's kind of like if you see meniscal tears, sometimes they tear into nice little pieces, but a lot of times they just kind of shred at the edges and they get really frayed. So this is a frayed, torn labrum that's really beaten up. I want to pause that one just so we can describe that a little bit. And then what we do basically is, here's the torn cartilage, there's the acetabulum. We shave the edge of the acetabular bone back. So if they have that pincer sign, we're shaving the bone back until all that bone is lined up properly. We don't have the crossover sign anymore on the x-ray. And then we put little anchors down into the bone, and those anchors have little eyelets so that now sticking out of the bone is some stitches. And we have what looks like kind of fancy sewing needles that go in them. They grab the stitch, they take it, they put it around the cartilage. We pull the stitches back out through a cannula or a little hollow tube, make some sliding knots, slide those sliding knots down, and then that way we're able to sew the labrum back down to that bone that's been recessed and prepared for the labrum to attach to it. When they were doing the initial labral repairs, their problem was they were doing all these steps, but they didn't take the bony anatomy back, and so the labrum kept getting bumped, and it would fail again fairly quickly. There we go. Let's see how much of it shows up. But basically, here we are grabbing the stitches after they've gone around the labrum. We're sliding our knots down. We're tying that labrum back down to the bone so that we've pushed the bone back, we've recessed the bone back, and now we've got the labrum further away. Here we're going to be on the femoral side. On the femoral side where the cam deformity is, again, we can see this on x-ray. We're going to take what looks like a Dremel that you might have in a workshop, except in a longer cannula, and we're going to burr that extra bone away. And that bone gets burred away and then pumped out through the cannula, so it's basically like the little bone dust gets pumped out right away. So you can see us cleaning up the edge. And instead of having a big flat area of femoral neck, which was impinging, hopefully this will show you at the end where we've created a nice scalloped out area for the hip to rotate so that it doesn't bump into the edge of the acetabulum. You can see we're cleaning that up. And we've created, usually it's about somewhere between 5 millimeters and a centimeter at the base of that trough. And we have the burr gives us a size, the burr is like 6.5 millimeters, so we can use that to gauge how much we're removing. At the same time we're removing that, we can look at it on x-ray and see that we're removing the proper amount. So in the end, we just kind of clean up the edges, and hopefully we have a picture to kind of show that for you. Here we go. This is the x-rays before and after. We take these x-rays while we're doing the surgery so we can be sure everything looks good before we're done. On the top, you're going to see that there's not a lot of room for the femur to rotate into. There's kind of a flat edge there. Plenty of room to rotate into here, but kind of flat on that side. And then when we're done, we scallop that area out. So there's plenty of room for the femur to rotate up and up into the acetabulum. Same thing over here. Two slightly different angles on the hip before and after. So removing the cam deformity, recessing back the pincer deformity, and sewing the labrum back down. After a patient has had a hip scope, particularly if they've had bony work on the femoral side, they go through a fairly prolonged therapy. I think you got a flash disc with some of the handouts. Not the whole therapy protocol is up here, and I don't think it turned out well in the flash disc. So if you want to, you can see the therapy protocol for after hip arthroscopy. We have that at the front here. I use a CPM machine. I think it helps them obtain better motion. Also, I think helps with cartilage nutrition. So they'll be in a CPM machine several hours a day for the first several weeks. And then that's not the part the patients will complain about or dislike. They also have to be on crutches for approximately 4 weeks afterwards so they don't develop a stress fracture of the femoral neck where we've thinned the femoral neck out. So they have to be on crutches and be at most toe touch weight bearing until that bone has had a chance to really congeal and get stronger. So, and the hard part is, the hip scope hurts for a few days. A week or two later, it really doesn't hurt that much anymore, and so patients have to be disciplined to not walk on it. Because if they walk on it, it won't hurt right away, but if they were to walk on it enough to get a stress fracture, that would be a big problem. So after patients have had their hip scope, they want to return to their sport. They're returning to sports. Obviously, it's sports specific. Some sports are a little bit harder to get back to. Other sports they get back to sooner. But basically, they're doing sport specific training, things related to their sport in 3 to 4 months. I would anticipate them not playing on the team, in competitive sports for 6 to 9 months after surgery. So it's a pretty big surgery, even a little bit longer recovery, perhaps than the ACL, more on the line of a bank card. I don't do bank cards, but I remember that's how long they used to take. So in conclusion, basically, you're going to see patients who have this problem. In the past, they're going to be diagnosed with chronic groin pain or chronic groin strains or hernias that nobody could really find. So these patients are going to be in your practice of athletic training. Be especially concerned about the volleyball players and hockey players who have groin problems that just don't seem to go away. It's a common problem, not difficult to diagnose. Remember the twisting the hip and just seeing if they don't have the normal range of motion there. And our current treatment is effective in returning people to their activities. The focus of this talk was on the athletic patient and the labral tear, but it's good to know that you may catch a patient early on in their lifetime, diagnose this problem. If they get it corrected, you may prevent them from needing a hip replacement as a young adult. And it's very devastating for these people. They're typically married, young children, having a job, and all this, a minivan, 2.5 kids, and a mortgage, and they've got to stop for a few months to have a major reconstruction is a big deal. That's my family there at a conference somewhere visiting. Any questions? We should have some time for questions. Lynn, how are we doing for time?
We're good.
Good. So, any questions on this? Yes.
You see this in younger athletes, like, for example, like the 8 to 12-year-olds and like the hockey players and that, and would your course of action be different?
Yeah, if they're not skeletally mature, we really would not do a proximal femoral osteoplasty because their growth plate is right there. So anybody who's going to have a surgical treatment has to be skeletally mature. For young women, that tends to be around 14, 15. For men, it's more 16, 18. If I had a kid who had really a bad cam lesion and he's 10 and he has a markedly positive impingement test, I'd encourage his folks to change his sport. Reinhold Gans, you know how we screen kids for scoliosis in the United States in school? Reinhold Gans is starting a screening program for all athletes in Germany for hip impingement. If they have it, they either get it corrected or they can't participate in a list of sports. So I think if I have a 10-year-old and he likes hockey, but he's 10, you can make him like something else, and his hip is really bad, that I'd try to direct him into a different sport which wouldn't be as hard on his hips. So we do see some kids. Obviously, at that age, for them to have symptoms, they have to be pushing themselves pretty hard. They're the kids in the traveling teams, plus this team, plus that team, and they're bumping those hips over and over and over again. But we do see some of those kids with symptoms who are skeletally immature. I advise that they avoid those activities, and we'll reassess them when they're done growing or as they get closer to being done growing. But that's a good question, very good question, because they're not a candidate for surgical correction until their hips are done developing. Good question. In the back there.
What are the odds of incurring nerve damage from an open procedure, especially if I have a surgeon who does a more anterior approach?
That's a good question. The largest published series on open correction from acetabular impingement are from Reinhold Gans, and he has very good results. The things we worried about, you worry about nerve damage. If you're talking about direct anterior, you're worried about the lateral femoral cutaneous nerve. Even though it doesn't go to the muscles, if you ding that nerve, it really is irritated. I haven't seen a percentage, but with the anterior approach, that would be a risk. The Reinhold Gans classic description, the one that I use, is a posterolateral approach, so you're not near the lateral femoral cutaneous nerve. The biggest thing we all worried about a lot was avascular necrosis. The ligamentum teres a little cord that attaches the ball to the cup. There's a tiny little, looks like a tiny little umbilical cord in there. Whenever you dislocate the hip, you have to cut that, and that does carry some blood supply. At least in Gans' series and in my practice, I haven't seen anybody with avascular necrosis. So we worry about avascular necrosis. Any open surgery, you worry more about infection, you worry about nerve problems. I don't have a percentage for you, but the anterior approach, the lateral femoral cutaneous nerve, whether it's anterior approach for hip resurfacing or for a hip decompression, has that complication associated with it. There's actually a kind of a hybrid surgery that some surgeons do. They scope the hip, and then they make a mini anterior approach to go down and take off that pincer lesion and carve off the front of the femur, since that's where most of the pathology is, right in front. And that would be the group of surgeons who, they should publish like a large series and see how many lateral femoral cutaneous nerve palsies they have to get a number on that. But that's a very good question. Good. Yes, right there.
Are there other injuries that you commonly see associated with impingement?
Well, besides the labral tear, which is how a lot of patients present, let's take a typical patient with femoral acetabular impingement. They've had growing pain for a couple of years. They finally get an MRI, and if they don't have a labral tear, that's often the end of their evaluation. But some of those patients, the labrum is still hanging on to the bone, but that cartilage on the acetabulum right next to the labrum is also seeing a lot of force, and they're getting an osteochondral injury that is substantial and not easily picked up on MRI. So that's probably the next greatest group of patients I see, is patients who they have a lot of impingement, but somehow the labrum is not coming detached, but they're damaging their articular cartilage right next to the labrum, and those patients can end up with pretty difficult problems to treat later on because we don't have a way of putting that articular cartilage back, obviously. And I think that's the next most common lesion. No labral tear, substantial hip pain, impingement that results in osteochondral damage or damage to the cartilage on the surface of the bone rather than the labrum. It's a great question, though. Good. Yes, over here.
I worked with a very overweight basketball coach who had a groin pull that led him to see an orthopedic surgeon 2 years later, and he has all these signs and symptoms, and we're wondering what else we can do with him prior to him going to surgery. The stretching that's been working is hip adduction, extension, and staying away from the internal rotation. Stretching, working, practicing more stretching, etc. And stretching groin, abduction. Any other suggestions?
Well, I think exactly what you're saying. Try to avoid the impingement, core stuff, so that he has good control of where his hip is and when he's doing different activities. Obviously, weight loss is a huge thing. It's hard, obviously. These patients, by the time they come to you, their groins hurt, they can't go burn 600 calories exercising anymore. They just have to starve. So get them to lose some weight. And then I do abdominal strengthening, but without getting to the point of flexing up where the hip is going to pinch. I think those are the right sort of things. The papers I would like to see that haven't yet been published